as the medical director for an organisation called NSD, National Services, which works on behalf of all of the health boards in NHS Scotland, to bring together the very specialist end of healthcare, both delivered here in Scotland and when we buy things south of the border. But in fact, in this field, we actually believe that we're ahead of the game. And really the next 10 minutes is about just explaining how we go about organising specialised services in Scotland and how we continue to work with our colleagues that we commission to ensure that we are staying at the front of the curve. So just a short slide on NSD's purpose, which is about high quality, effective national specialist health and screening services. And the screening is important, that whilst we commission breast screening, cervical screening, bowel screening, which a number of you will have benefited from, as it stands at the moment, and whilst it's related to this topic, we do not do genetic screening per se, but that may come up in the discussion over this afternoon. Very briefly, NSD, and my job is a wonderful one, which covers screening programmes, national projects. We touched earlier on the need for improvements in gamete donation, sperm gamete donation, and I've been asked to chair a group on behalf of NHS Scotland to try and improve that position, because in reality there are still a lot of things that we need to do to improve the infrastructure for all of this work in terms of IVF and related services. I've touched on the cross-boundary work, but this afternoon we're obviously looking at one of our specialist services. And by definition, they need to be related to something that's complex, and I think you've already heard from Margot's presentation the number of different topics that need to come together, different disciplines to work for and with an individual to achieve a good outcome. Cost is an issue, and it used to be the case that it was high cost, low volume. We try very hard to not ignore cost, because we can't do that in current times, but we do very much regard cost as something that it's an investment for change, and if we can actually ensure that we get a good outcome, we can often argue for that additional cost. But volumes, this is still, despite the advances that you're going to hear about this afternoon, a low volume in the sense that very few couples will be able to access the service that we have. And that is all the capacity that we have at the moment. But obviously this afternoon, and debate that will go on over the following months, it may be that we need to change the size of the service that we have. NHS Scotland, you will probably be aware from last summer, signed up to a concept of the healthcare quality strategy. And I'm confident that irrespective of what the decision is in May as to our future government, the healthcare quality strategy will continue as almost the spine of the backbone of what the NHS in Scotland is here to deliver. You'll all have read in the press about issues south of the border, and reassuringly, the debates about commissioning as such, moving from specialists to primary care or to something in between, do not as yet apply in Scotland. The three quality ambitions are to ensure that our healthcare services are person-centred. In other words, the users of the service are right at the heart of it. That we deliver a safe service, in other words, we do no harm, and more importantly, that we try and offer that service equitably across all persons, and that it's effective. In other words, that we are actually going to use the science that is available to actually make a difference. Each of our services are required to produce an annual report, and those cover the 6 domains of quality. That's the safe, effective, person-centred, efficient, i.e. that we're not costing an excessive amount, equitable, that we're actually providing a service to all of Scotland, and that there are no barriers for any individual, irrespective of their background, and timely, in other words, that we are still working within the time constraints that we all now expect of a health service. We have a service agreement, and in respect of the PGD service, that's running at just shy of £250,000 is the cost, so it's not inconsiderable, against an expectation that it can cope with up to 30 pregnancies. But as we've heard, that 30 pregnancies is unlikely to translate into 30 children. And there's an awful lot of working up before we even get to the stage of considering the actual IVF. And all our services are subject to a 5-yearly review. And NSAG is this national body, the National Specialist Advisory Group, which brings together lay people, chief executives from NHS, clinicians, to basically give advice as to what NHS Scotland should commission. But turning specifically to the PGD, whilst the service had been running as a Glasgow organised service from 2002, it became nationally commissioned in 2005 and was extended last year, and you'll hear about it shortly, to include the single gene testing. And we now have a partnership working between Glasgow and Edinburgh, which has been one of my privileges as medical director of NSD, to actually see Glasgow and Edinburgh working together. And in the NHS, that is a pleasant thing to see. It is technically complex and demanding, as you've already heard, and I'm sure this afternoon will further expand. It is emotionally charged, and a substantial part of what goes on is nothing to do with the science, it's to do with the humanity. Again, we'll touch on that this afternoon. But the counselling which is actually provided around this in terms of couples coming to make a decision that they want to enter into it. IVF is bad enough, PGD adds another whole dimension to the thinking that a couple have to go through. And it is clinically invasive. Margaret's pictures were very straightforward, and yes, it is technically possible, but it is in fact adding quite another layer onto what a couple will go through to achieve a pregnancy. I won't extend this because Margaret's already touched on it much more eloquently, but at the moment the service is really commissioned for NHS Scotland where there is a recognised risk of a predisposition. We do not at present have NHS funds for any of the other concepts of family balancing, or indeed for, well, it is now just for the risk of being predisposed. We also have to have confidence that there is a test available for the genetic disorder, and that is subject to a licence from the HFE. Thankfully, in terms of that detail, that is undertaken by my specialist colleagues within the service. And finally, this is part of the wider IVF service, and there is a significant discussion going on within NHS Scotland as to what are the eligibility criteria for IVF. And there are many who would argue that this is a luxury at a time when the country as a whole is actually struggling to actually fund basic care. And so there is in fact another element to the discussion today, which is that even if we can do it, should we be doing this? And to that end, we have and are currently working with an expert panel to actually guide both what is happening within the PGD service and more widely NHS Scotland in terms of ensuring that we have the same rules for IVF across Scotland. Because as Margaret said, Glasgow we have tolerated or in fact funded 3 cycles, but in fact there are other boards in NHS Scotland that did not. And in fact we want to try and get back to a place, not through the NSD funds, but through the NHS and Scotland funding. And of course, future developments, those very much are in the hands. And one thing that the Scottish Government has done, and it's not just the most recent one, but for the last 4 or 5, it has been listening to the people. And in fact, we try very hard to respond to what the public in Scotland say that they want from their health service. It is my job and my colleagues who are in the room to actually translate that wish into an actual practice. And so, last slide, really just to say that if there is a need, we need to actually link that to demonstration that there is a demand. And sometimes in our world there's lots of wants out there. It's about translating this into, is it one of a fundamental human right, to be able to extend, and I'm sure other speakers this afternoon will explore that further. The work that we do within NSD is guided by both national planning and regional planning. Scotland is very proud of being local. In other words, if it can be done locally or delivered locally or regionally, it will be. But things like this are very much done on national funding because they are so rare. and we obviously work straight to government with our national advisory groups. But at the end of the day, NSD, having been given the commission to ensure a service, works directly with the NHS board, in this case NHS Lothian, NHS Greater Glasgow and Clyde, works with both clinicians and the managers, and we do meet with them regularly. But critically, there is an expectation that the service, and indeed we ourselves, will meet directly with the patients, with the families and users, to ensure that we're doing what is actually expected of us. So, happy to take any questions. Please have a look at our website. You can go and have a look at the annual report for the service as it stands at the moment, and I'm very happy to take anything electronically by email after the session. So thank you very much.